Good evening, everyone. My name is Donna Duncan, and I am a member of the Board of Directors of Sunnybrook Health Sciences Center. It is my pleasure to welcome you to our March Speaker Series event. Earlier this month, it was Brain Awareness Week, a good time to learn about brain science and mental health. We are continuing that spirit of learning with tonight's talk focused on dealing with anxiety and obsessive compulsive disorder. Before we begin, I'd like to take this opportunity to say that at Sunnybrook, our mission is to care for patients and their families when it matters most. It's part of what makes this place just so special. Sunnybrook also cares about our collective responsibility to achieve reconciliation with Indigenous peoples who have lived on this land for generations upon generations. We acknowledge our campuses are located on the treaty territory of the Mississaugas of the Credit First Nation and ancestral and traditional lands of the Anishinaabe, the Haudenosaunee, the Ojibwe, Chippewa, and Huron-Wendat nations. Today, this land is home to many First Nations, Inuit, Métis, and urban Indigenous peoples from across Turtle Island. We value their contributions, past and present, and we are grateful to work in the community on this territory. So, why are we discussing anxiety and obsessive compulsive disorder? Well, anxiety disorders affect a large number of Canadians, according to Statistics Canada. In 2022, more than 5 million Canadians met the diagnostic criteria for a mood, anxiety, or substance use disorder, and the prevalence of mood and anxiety disorders has increased. In fact, the percentage of Canadians aged 15 and older with a generalized anxiety disorder doubled from 2012 to 2022. Obsessive compulsive disorder, or OCD, is an anxiety disorder that affects about 1 to 2% of the population, according to Anxiety Canada. Depending on the severity of the symptoms, OCD can have a profound negative impact on people's lives, often interfering with school, work, and social interactions and relationships. The good news is that there are highly effective, evidence-based treatments available to help people manage and live with anxiety and OCD. Sunnybrook's Hurwitz Brain Sciences program is driving innovation in treatment and brain health, including mood and anxiety disorders. Our Department of Psychiatry brings together compassionate and highly specialized expertise in understanding and treating severe mental disorders. It is also home to the Frederick W. Thompson Anxiety Disorder Centers, which offers interprofessional treatment of severe OCD and related disorders through its unique residential program and day treatment program. In fact, the Thompson Center is truly special as it runs Canada's only intensive treatment program for OCD. Tonight, you will hear from key members of the Thompson Center team. They will share their insights on what anxiety and OCD is, when to seek help, and common techniques for managing these conditions. You will also hear from someone with lived experience with OCD who has gone through the treatment and will share some of the things she has learned along the way. We are fortunate to have Dr. Sonu Gand moderate this event. Dr. Gand is chief of the Department of Psychiatry at Sunnybrook. He is also a professor in the Department of Psychiatry at the University of Toronto. From 2017 to 2020, Dr. Gand represented Canada as a board member of the World Psychiatric Association. In 2021, he was awarded Distinguished Fellow of the American Psychiatric Association. Dr. Gand has been actively involved in mental health policy development and advocacy and has been recognized with numerous regional, provincial, national, and international awards for his teaching, advocacy, and impact. This is just a snapshot of Dr. Gand's biography. As you can see, we are in excellent hands having him moderate tonight's panel discussion. So with that, Sonu, thank you so much for being here. I will now pass the microphone and the event over to you. Thank you, everyone.
Thank you so much, Donna, both for that introduction and also for your support and the support of senior leadership of the mental health program and psychiatry at Sunnybrook and all of the patients and families we serve. And also welcome and good evening to all of you joining us tonight to learn about dealing with anxiety and obsessive compulsive disorder, or OCD. As you'll hear shortly, Sunnybrook has leading expertise in caring for people with mood and anxiety disorders such as OCD. Sunnybrook's Hurwitz Brain Sciences program and the Department of Psychiatry are proud to house the Frederick W. Thompson Anxiety Disorder Center. The center is renowned for the comprehensive and highly specialized care it provides to people with severely impairing OCD and related spectrum disorders. Interprofessional teams, including psychiatrists, nurses, social workers, occupational therapists, and research staff, work with clients from across Canada and the United States to reach positive outcomes. Tonight, we hope that you'll come away with an introductory understanding of anxiety and OCD, as well as some proven management techniques. Dr. Peggy Richter will start the evening off by providing a brief explanation of what anxiety and OCD are, common symptoms, and how to recognize when it's time to seek professional help. But what does sound effective help actually look like? That's what our second speaker, Aliza Ladak, will discuss. Aliza will provide an overview of commonly used and successful treatments for anxiety and OCD, such as cognitive behavior therapy, or CBT, and mindfulness practices. Finally, we are very fortunate to be able to hear from one of our former patients' remarkable journeys. Casey Josephson is a registered nurse in Saskatchewan who received care at the Frederick W. Thompson Anxiety Disorder Center as part of its cutting-edge residential program. And we're highly appreciative that Casey will tonight share her story of living with anxiety and OCD. So as you can tell, there's a lot of ground to cover. We'll set aside some time at the end for you to ask our speakers your questions. And also thank you to everyone who's already submitted a question online. Please feel free to also send your questions through our speaker series webpage while the presentations are happening. And while we may not be able to get to every question, we will do our utmost to try to answer what we can in the time we have available. So to begin the lectures, I'd like to introduce our first speaker. Dr. Peggy Richter is a psychiatrist and head of the Frederick W. Thompson Anxiety Disorder Center. She's also an associate scientist at the Hurwitz Brain Sciences Research Program at Sunnybrook Research Institute and a full professor in the Department of Psychiatry at the University of Toronto. Dr. Richter is internationally recognized for her work in the field of obsessive compulsive disorder. Her research focuses on the genetic and biological basis of this illness and aims to better define the boundaries of OCD and related spectrum disorders and to improve treatment outcomes. She is also an acclaimed speaker on anxiety and presents extensively to healthcare professionals and public audiences, and we are sure you will learn a great deal from her tonight. And so with that, Peggy, thank you for joining the panel, and I will hand it over to you.
Thanks so much, Sonu, and thank you to all of you who are attending live today or perhaps at a later date. It's always a pleasure for us to be able to share some of what we've learned over the years with a broader audience. Let me just get my slides up. Okay, hopefully that is looking appropriate to everybody. Yeah, good. Okay. Great. I'm just going to get my view back up. There I go. Well, thanks again so much for the lovely introduction. So my goal is, as Dr. Gaines has shared with you, is really to kind of take us on a bit of a whirlwind tour through anxiety and OCD with a focus on when to seek help and a little bit of an overview of some of the resources that are out there and the treatments that are out there. I want to bring this to people's attention. If anybody finds this talk to be triggering for them or is dealing with with their own difficulties, there is always help available 24/7 by calling or texting the Suicide Crisis Helpline 911, or for mental health resources, you can also visit Sunnybrook's Department of Psychiatry webpage. And you can also go in through the image on your screen in your camera. I'm also going to show that at the end of the talk, should anybody wish to see it again. So let's start with an overview of anxiety. I think it's important to highlight that anxiety in and of itself is totally normal, part of the human experience, and in fact, important for long-term survival. We all experience anxiety or symptoms like it all the time. The issue is whether there is a realistic, clear source of danger when you're experiencing it or not. So, for example, if I'm crossing a busy Toronto street and I see a bus coming down at me, it is perfectly normal and, in fact, will enhance survival if I experience a rush of adrenaline and the associated physical feelings that come on with that, which in another situation might be deemed as an exaggerated or inappropriate anxiety response. So that's really where we define it. If there is a clear source of danger, we consider it adaptive and helpful. But when our body gets these false alarms or is triggered in situations where there is no danger, that's when we begin to think of it as problematic anxiety. So this was probably selected for through evolution. Our ancestors only survived because they had these good adaptive responses to life-threatening situations like this one. I wouldn't want to be that close and personal with this entity either. And it enhances our survival in the long run. Another more contemporary threat there. So when do we think of it as a problem? When it becomes persistent and when the symptoms are getting in the way of our ability to function in our daily lives. For example, if we're no longer able to function normally at work, at home, in our relationships, if the anxiety and the symptoms are far in excess of what we would consider kind of normal and reasonable, or if we're distressed by them. So somebody, depending on our threshold, may have limited symptoms, but if they are finding them heavily distressing, that's certainly a reason to go seek help as well. And certainly if they're persistent or getting in the way of functioning. And as we've already heard today, anxiety disorders are extremely common. In fact, they're often considered the most common of the mental health conditions, with an estimated lifetime prevalence, or the likelihood that you will develop one of these conditions over your lifetime at about 1 in 3 adults in the population. That's huge. Having said that, we have this funny paradox, which is that although we know that anxiety disorders are so prevalent and cause significant issues, they tend to be very much under-recognized by people themselves and by healthcare professionals you may seek help from, such that it's been estimated that about 40% of people even diagnosed with these conditions are completely untreated. And ironically, even when people receive treatment, it's been estimated that only about 1 in 4 are getting what we know to be effective treatment based on the evidence we have accumulated over the years. So there are these big challenges around getting help with anxiety disorders for these reasons in the population. In OCD, these shortfalls can be even worse. It's been estimated that 70% of people with OCD remain undiagnosed even when seeking help from a psychiatrist. And amongst those with OCD who, in terms of getting help, only about 1/3, even of those with really serious OCD, receive treatment in a typical 1-year period, and a minimal percentage of people with mild to moderate symptoms who are nonetheless impaired or distressed by their issues. We're going to be talking more about what the most effective treatments are in a moment, but CBT is one of them, and that is cognitive behavioral therapy. It should be a mainstay of treatment, and yet less than 1/3 of people with OCD will receive appropriate, effective CBT, And of the medications that are out there that work, it's actually the rule rather than the exception, even for psychiatrists, to prescribe these medications at what would be very appropriate dosages for depression, but maybe at too low to be optimally effective for OCD. So again, major shortfalls in the way care is offered. So what are the disorders I'm referring to? I'm going to just briefly show this to say there are quite a host of disorders, and I'm going to be speaking to the major anxiety disorders and OCD tonight. These are grouped according to the Diagnostic and Statistical Manual put out by the American Psychiatric Association, which many of us laughingly refer to as our Bible in terms of diagnosis of psychiatry in North America, very similar to what is used in Europe, and actually DSM is followed around most of the world. So we're going to be focusing on the major conditions in the anxiety group as well as OCD tonight. So what are these different disorders? I'm going to try and give everybody a very quick introduction and hopefully a bit of a feel about the differences between these different conditions that all get lumped together in the anxiety disorder category. We have generalized anxiety disorder, which is a disorder of excessive worry. So these are worries that would be familiar to all of us. We all experience them. Concerns about our health, our finances, our family, our relationships, our children, our future, you name it. The problem with generalized anxiety disorder is that people will experience this excessively and persistently over 6 months or longer, to the point that often they experience other impacts of being chronically anxious, such as being irritable, feeling like they have their heart pounding, feeling like they're getting tension headaches or back pain, that they have trouble concentrating or difficulty sleeping, as examples. Panic disorder, by contrast, is characterized by the presence of panic attacks. And panic attacks are generally described as simply very sudden onsets of very intense anxiety, sometimes coming out of the blue. For other people, they will come on with triggers, in which we experience very intense anxiety or panic with a host of physical symptoms, such as feeling short of breath, having your heart go very rapidly, or pound, or get palpitations, or even chest pain. People may experience dizziness, faintness, shakiness, sweating, and even feelings at times and thoughts that they're about to die. It will feel intensely dangerous to them in the moment. Now, those are panic attacks, which can occur in all kinds of situations and are actually fairly commonplace across the whole spectrum of disorders we're discussing tonight. But when people have recurrent attacks that come out of the blue, that's when we begin to call it a panic disorder, where people begin to worry about their attacks and when they will happen, or change their behavior to try and manage them better. Agoraphobia is a related condition in which people are often fearful of their panic attacks and of being in places from which escape may be difficult or help isn't available. And so paradoxically, this will include both wide open spaces like the Costco parking lot after midnight when there's nobody there to help you should you feel unwell and collapse, or crowded elevators, or more than that, perhaps crowded shopping malls where you might not be noticed. And so people with agoraphobia will often avoid a number of these kinds of triggering situations. Social anxiety disorder is a fear of being embarrassed or humiliated in typically what we would call social situations, such as speaking with strangers, for many even speaking with friends or family, making eye contact with people, being assertive in one's behavior, eating with others, speaking in front of others, and other kinds of performance situations are also very common triggers. But again, I want to point out this goes beyond ordinary shyness. As with all these conditions, we're looking at the presence of excessive distress or impairment as a result of this. Specific phobias, I think, are familiar to everybody. Here we're talking about irrational and intense fears of a number of kinds of triggers, such as animals, whether it be rodents or dogs or snakes, natural environments such as heights or storms, blood or injection injury type, in which people typically will describe often feeling faint at the sight of blood or if they have to give blood, and certain other kinds of situation triggers, such as planes, elevators, other enclosed spaces. Now, although OCD and PTSD are not classically any longer considered part of that category of anxiety disorders, they are characterized by intense anxiety, and certainly historically have been included in this category and are still considered very close relatives. And so I'm also, obviously we're talking about OCD tonight, and I thought I'd also introduce PTSD as part of this. So OCD is a bit different in that it's characterized by unwanted, intrusive, persistent thoughts or obsessions and repetitive behaviors that people often engage in to try and alleviate their anxiety. And most of us are familiar with some of the more common types of OCD. For example, people with obsessions around dirt or getting sick, making others ill through germs, might engage in a lot of washing and cleaning rituals and avoid shaking hands, having to wash their hands more than others, and so forth. For others, it may be a fear of being responsible for harm or making mistakes, and that can lead to a lot of checking rituals, whether it's checking the doors and the locks and the faucets when they're leaving the house, checking emails to make sure they didn't say something offensive by mistake in their message, or checking with others to make sure they expressed themselves correctly. Those would all be variants on a theme. But OCD can really be about anything and everything. And then post-traumatic stress disorder, or PTSD, I think is probably familiar to most everybody and is traditionally diagnosed in the context of individuals who have experienced or witnessed a highly traumatic event. And it's characterized by a whole host of symptoms persisting at least 6 months or longer after the initial trigger, including recurrent memories, dreams, feeling like one's reliving the experiences, avoidance of triggering things or things that may resemble the situation you were in that was so frightening, or feelings of emotional numbness where people don't experience the full range of emotions, or feelings of irritability or physiological arousal, which would include things like racing heart, being on edge, being irritable, not sleeping well, etc. So that rounds out a quick bird's eye view, I think, of the major anxiety disorders. And I think I'm going to skip. Sorry, this was just a slide summarizing, again, the major context of the fears for each of them. So what are the major treatments we have out there? Well, we have good news and bad news, I would say. The good news is that we have treatments that do work, and they help most people substantially. However, the bad news, as I mentioned before, is that sometimes it can be difficult to access help, difficult to get the correct diagnosis, and challenging at times to find a therapist who actually knows the appropriate way to treat these conditions. But we're going to talk more about these two specific options, both CBT and medications. And I'm going to show a disclaimer because I do come in with a bit of a bias as somebody who uses both medication and CBT. I firmly feel that CBT is the more effective treatment, and that is not just personal opinion, although I may joke about it being that. It's actually based on the evidence we have available to us, which is that in terms of longer-term benefit, CBT certainly does come out stronger, but it involves a lot more challenges in actually improving with it, and medication can be very important to many people and maybe a better starting point for some. So part of the decision tree that we have to think about when choosing between these options, whether it's somebody like myself as a prescriber or somebody experiencing the challenge of their anxiety and trying to decide which kind of treatment is most compatible with where they are in life, is to think about these factors, such as the fact that medication can be relatively easy to take. The medications we use for the anxiety disorders and OCD are all very safe. And my ... there is supposed to represent that they work for the anxiety disorders, but have a very broad spectrum of effect as well. So they will treat depression very effectively. They can work for a variety of other conditions as well. On the downside, the benefit of any one medication can be very limited. Many people will have to try a number of medications to find one that best agrees with them with minimal side effects and with good benefits. And there is quite a considerable risk of relapse when people, or if people discontinue them. Now, cognitive behavioral therapy, or CBT by contrast, is extremely effective, long-acting in its benefits, and very safe, but requires really diligent hard work and being willing to challenge oneself and experience the anxiety, which for many people may be difficult depending on where they're at in life. It can also be more complex when there are multiple problems in the picture and there's an issue of access, although that is improving for Ontarians, and I'm going to show people some links at the end of this talk to assist with that as well. And at the end of the day, it really comes down to individual preference between these two options. So before starting treatment, there are certain ingredients and things to think about and to look for when you meet with a professional. Psychoeducation, or being taught about the condition you have and the kind of treatment, is really helpful for people with anxiety conditions. Very often, they thought it was just them. They blame themselves for the difficulties. Family members may see them as being somehow deficient or defective because they're not moving forward with their lives the way they so obviously seem capable of doing. And so people may not understand it and get it. And just simply understanding better about the basis of the condition and the treatment is so helpful. A careful history needs to be taken by any healthcare provider to be clear about what the actual diagnosis is and to make sure that the appropriate treatment is recommended. And depending on the presentation, that sometimes may include need for a physical exam, blood work, a cardiogram or EKG to look at one's heart health, and other types of investigations, although for many these are not necessary, so that's certainly not a blanket rule. It can be really helpful to begin keeping a symptom diary when considering starting treatment, because that will both inform you of where you're at right now and enable you and your healthcare provider to have a better sense as to whether the treatment is helping you over time. So beginning to keep a little diary of when you have panic attacks, when your anxiety's been highly triggered, whether it's social situations, by phobias, or because of a lot of worry. If there are rituals or compulsions in the case of OCD, what the big triggers for those compulsions and what the major compulsions are can be really helpful to begin to build one's awareness by keeping a diary. And of course, learning more about it, whether it's on the World Wide Web, through books, or other types of sources of information. But we do want to make sure that people find reliable sources. And I mention this because on the internet, it's so easy to find anything and everything, but it isn't always vetoed. Certainly there's no vetoing of what people can post. And so you want to look at sources that have some backing behind them as reliable sources of information. I'm going to just give you a brief introduction in the last few minutes of what these treatments look like a little bit, although we're going to be hearing more from Eliza about this and from Cassie with her experience with them. But cognitive behavioral therapy is a type of therapy where we focus on the links between our thoughts, feelings, and behaviors. And the C there, standing for cognitive, refers to the fact that we want to, over time, begin to recognize and address maladaptive or unhelpful thought styles. Thoughts that may come automatically into one's mind that are typically negative, seeing ourselves as incapable, seeing the world as more dangerous, viewing ourselves as a failure, and so on. In the B for behavioral piece, we're focusing on the behaviors that are causing the problems as well. In the case of anxiety disorders, it's often avoidance of various situations that are triggering of our anxiety. And so we will begin to do what's called exposure work in the case of most of the anxiety disorders. And in the case of OCD specifically, we will also add in response prevention to the exposure, meaning beginning to challenge oneself by going to the situations that trigger you or handling things that are triggering without doing those rituals, as an example, and we'll have more about this. We typically do this according to what we often call a hierarchy, or another cuter way of referring to it is as a fear ladder, for example. So the idea here is that we will want to identify a number of things that are triggering for us and begin to routinely practice challenging ourselves by doing exposure to these triggers, starting with things that are maybe not very scary near the bottom of the ladder, and eventually moving up to things that are intensely frightening, but that are important in terms of our life. So for somebody with social anxiety, for example, they might want to start by practicing a presentation in front of a mirror or in front of a sibling or relative, somebody who feels very safe, moving up to doing a presentation in terms of a group of friends, eventually moving on to harder situations like being assertive with a waiter, giving negative feedback about food, for example, in a restaurant, or even creating a video on Facebook, or public speaking, which in this example is right at the top of this person's fear ladder. Another example for somebody with a phobia, with a fear of dogs, for example, might start with looking at simply pictures of dogs or cartoons of dogs, which may nonetheless be somewhat triggering, and eventually working up to going to dog parks and stroking dogs. And often we will rate our anxieties on a ladder or a scale of 0 to 100, which is usually referred to as our subjective units of distress. So it's our own personal attachment of a score to the fear that we get in these situations. In the case of people with OCD, for somebody with concerns about germs, for example, they might have something fairly low down on their hierarchy, like touching doorknobs that feel relatively safe. But up near the top of their ladder might be this very challenging situation, public washrooms, which are often triggering. And we will often even think about what we might call overcorrection, where we might want to work up to something like this. And many of you might say, well, I don't want to use a washroom like that, and I would be one of you. But when we think about it, one of the things that's important when treating any anxiety condition is we want people afterwards to have the freedom to handle what life throws at us routinely and to be free to choose their activities. So if going to the X or being out of the home for an entire day and maybe at a public fairground or something is part of what you want to be able to do, we need to be able to cope on occasion with situations like this if there's no alternative. In terms of the medications, the mainstay family of medications that we typically start treatment with for any of the anxiety disorders or for OCD are called the SSRI antidepressants. That stands for selective serotonin reuptake inhibitors. These are medications that work specifically on the neurotransmitter or neurochemical serotonin, which is pretty ubiquitous in the brain, but is pretty clearly highly involved in anxiety, in depression, in suicidal thinking, in eating disorders, in a host of conditions. So it's not necessarily all that specific, but we do know from many decades of evidence now that these drugs work extremely well for anxiety disorders and for OCD. They also tend to be very well tolerated and very safe, and these are names of the most common agents that we currently prescribe here. There are other types of medications that may have roles in anxiety, and getting into the details is beyond the scope of today's talk, but for reference, I thought I would just introduce there are other types of antidepressants, such as the serotonin and norepinephrine reuptake inhibitors. Similarly to the SSRIs, they do work on serotonin as well as another neurotransmitter system. And then there's a limited role for other types of antidepressants, termed the tricyclic antidepressants, another family, the monoamine oxidase inhibitors. There is one medication in this class under the name of NASA, which stands for noradrenergic and specific serotonergic antidepressants, and limited roles as well for other types of drugs like antipsychotics, anticonvulsants, and glutamatergic agents. I'll briefly just mention benzodiazepines, drugs that are in very common use, like lorazepam or Ativan, as it's known by, or clonazepam or Rivotril, are very commonly prescribed. And they do help with anxiety in the short term. The problem with these medications is that they don't tend to reduce symptoms significantly in the long term, in the sense that they will give you the kind of relief taking a Tylenol will when you have pneumonia. You get a brief period of well-being or feeling less feverish, but the underlying problem is still there and comes back as soon as the medication effect wanes. And they can be associated with problems with long-term use in terms of physiological and psychological dependence, feeling a need for them, tolerance where we need more of them to get the same effect, and withdrawal if they're stopped too abruptly, and they can affect thinking processes and our reaction time. So these are not drugs we want to be routinely going to for relief. In terms of the medications and the antidepressants specifically, in general, higher doses work best for anxiety and for OCD. And it can take quite a bit of time to get really good responses, longer than is typical in depression. So I'm going to show it to you graphically this way. In depression, typically most people do quite well with lower doses or mid-range doses, and we'll typically see good benefits within 4 weeks. When we talk about the anxiety disorders, we're talking about a higher dose, usually being slightly more effective, and often taking 6 to 8 weeks to really see a good response. And in OCD, we're often going to higher doses than are even routinely recommended for other conditions at all, and often taking 6 to 10 weeks to see really full effects. So higher doses and longer trials for these conditions. And I wanted to highlight that I think, as we already heard from Donna, the pandemic's been hard on people and has really affected most of us in significant ways. And even though we now feel like we're mostly out the other end, with most of us back to relatively normal lives, although they may not look quite the same as they did pre-pandemic, levels of anxiety and depression are still about double the pre-COVID numbers. So these have really had an impact, and this is just showing it another way here, showing the prevalence of depression being much higher compared to 2012 in this example versus 2022. Bipolar disorder or manic depression increased modestly, but generalized anxiety and social anxiety, two other anxiety disorders, markedly increased as well. And there's also beginning to be a clear upswing in what's termed eco-anxiety or climate anxiety. And I didn't want to belabor it in this talk, but I think it's important as we think forward and into the future that more and more people, especially younger adults and teens, are really experiencing a lot of heightened anxiety about the changes in the climate. And this is something I think we're all going to have to grapple with over time. So when do you seek help? You want to think about looking for certain signs about when to seek help, such as feeling excessively worried or sad. If keeping up with your everyday activities, such as work or school, is becoming a problem, that's usually a good indication that help might be useful. Or withdrawing from friends or family and finding it hard to interact with people. Trouble keeping up with even the very basic daily tasks we need to do to maintain our well-being. Eating, sleeping, grooming is another indicator, and physical symptoms can often be associated with the anxiety disorders. So what can you do when to seek help? Well, I mentioned before getting informed, looking at self-help books, looking on the internet, talking to friends and family, and then a number of general resources in the community. Family doctors are always a good place to start, although unfortunately we know there is unfortunately a fair proportion of Ontarians now without good access to family doctors, but at least a walk-in practitioner may also be able to start you on that path and recognize the problem. The Canadian Mental Health Association has a really good listing of resources and offers some groups, as does the Mood Disorder Association of Ontario, also known now as Hope and Me. And there are also other unaffiliated community support groups. I've listed our Thompson website, although I will say we are really very much more focused on OCD and the related conditions, but there are other places to go. There are also a lot of apps that are available free to some extent. So all of these have some free portion of their services available. Mindshift CBT is put out by Anxiety Canada, which I've listed down here, which has wonderful online resources, as well as self-help courses you can do. And they are also behind the Mindshift app, which is made available totally free to people and offers a nice brief course of cognitive behavioral therapy. The Centre for Clinical Interventions is an Australian website with also a lot of good resources in it. And I wanted to mention that in Ontario, we also have a couple of new initiatives. We have what's called the Ontario Structured Psychotherapy Program, and it offers a range of interventions, including self-help and bibliotherapy, reading material. Bounce Back is an online CBT program that is available totally free through them and can include some therapist involvement. And at the far end, it can also include group CBT for people with all of these anxiety disorders, and even some limited individual CBT. People can be referred by their doctor, or they can self-refer if they go to the website, which is why I've also included it in this slide deck. So this is really wonderful and is increasingly available all around the province. And then I have a list here of some other internet resources just to highlight for you. So these are all good ones, beginning with Anxiety Canada, which I've already mentioned, and including a few other very good organizations. And so I mentioned this again is an easy way to access Sunnybrook Department of Psychiatry's web pages, which also have a lot of information. On that note, I'll stop here. Thank you so much.
Thanks very much, Peggy. That was a fantastic overview, very wide-ranging, and you covered a lot of ground and gave a lot of really phenomenal information. I think we'll move on to our next presenter, who is Eliza Ladak, and she's an occupational therapist practicing in the area of psychotherapy at the Frederick W. Thompson Anxiety Disorder Center. Eliza is an OCD and anxiety specialist with experience working with various severities and subtypes to help clients reclaim their lives and relationships from anxiety and OCD. We're very fortunate that Eliza is here with us to share expertise on techniques to manage anxiety and OCD. And with that, I'll pass the microphone over to you, Eliza.
Great, thank you. I'll just pull my slides up. Okay, good evening, everyone. I'm really excited to be here tonight and speak about techniques for managing anxiety and OCD. This is the agenda. My hope for tonight is really that you walk away with some practical, concrete things that you can try out right away and learn a little bit more information about some evidence-based therapies that are used for the treatment of anxiety and OCD. To start things off, I thought we could do an experiential exercise together. We're about, over an hour into this talk. You might have noticed that your mind is wandering, or maybe there are some hunger cues from the body showing up. And the 3-minute breathing space is an exercise that we can do to step out of automatic pilot mode and come back to the present moment. It can help us slow down so that we can better respond to stressful situations. The goal is not to take away negative feelings, so your hunger cues will not go away after this practice, but rather just to practice being with your stuff, being with your inside world in a different way. So I'll guide us through this, and if you'd like, you can try it out with me. So let's start by take a moment to get comfortable in your seat. I'll invite you to close your eyes if that feels okay for you, or lower your gaze away from the screen. You can place both feet flat on the floor. Rest your arms comfortably, palms facing up or down. And let's start by becoming aware of the present moment. Notice what is going on with you right now. Open to your inner experience. Notice what thoughts are going through your mind. And as best you can, label the thought as simply a thought. Notice what feelings or emotions are showing up inside. And can you try to stay with the feeling? See if you can even turn towards it. What body sensations are here right now? You can note any tension or tightness that might be present, perhaps in your shoulders, neck, jaw, or low back. Continue being open to this for a moment. Now bring your attention to the breath. Down in your abdomen as you breathe in and out. There's no need to change the breath in this moment. Simply observe how it's happening here and now. Notice the rise and fall of your belly and chest with each in-breath and out-breath. Use the breath to anchor you in this moment. And if the mind wanders, as all minds do, gently try and bring your attention back to the breath and the sensations of breathing. Now, let's try and expand awareness to the body as a whole. Bring your awareness to the sensations or lack of sensations from the top of your head down to the toes. Notice the temperature on the skin. Once again, see if you can allow the sensations to be exactly as you find them. There's no need to change anything right now. A sense of opening up to what's here with curiosity. Now, when you are ready, we will end this practice by beginning to move your fingers and your toes, letting your eyes open if they were closed, and bringing your attention back to the room. Hey, thank you for those that tried that out. Quick word on the breath. This can be a real asset because it's automatic, it's always happening, and it travels with us everywhere we go. So you can use breath techniques in something more formal, like a breathing space, or you can just use the breath and ground yourself in any given moment wherever you are. It can be a tool for building awareness of what's going on inside, as well as for supporting yourself during an anxious moment. If you're not familiar with any breath work or using any breath techniques, you want to work with your abilities and start off slow. I'd encourage people to try this in different ways. You can try exercises laying down. Some people find it very grounding and calming to have their head and heart in the same alignment. Some people prefer doing these exercises sitting or standing. Consider the temperature of the room, the clothing that you're wearing to make it more comfortable. When you do it, sometimes after a big meal might not feel comfortable. And it's important to keep in mind there's no right or wrong way to breathe. Sometimes with certain types of anxiety conditions, if you're very sensitive to body noise, or you're very tuned in to your inside world and internal physical sensations, it might activate your anxiety symptoms. And if that's the case, then during an acute anxiety moment, this might not be a technique for you. but nonetheless, it is worth trying in a calm state to see if it can offer you any benefit. Another type of breathing exercise, different from the one that we started with, is called box breathing. I really like this one for beginners. The idea is we are tracing a square to complete a breath cycle. So we start by breathing in, hold, breathe out, hold, breathe in, hold, breathe out, hold. The pace is 1 to 1 to 1 to 1. So each component of the breath cycle takes about 2 to 3 seconds, and then you can repeat and cycle through that as much as you'd like. Sometimes it's helpful to have a reference of an image to keep you on that pace, or to trace it out with your hands as I was doing. Mindfulness is something I'm sure many people here have heard about. We're hearing more and more about this in mainstream media. It has origins in Eastern cultures and philosophy, and now has made its way to the Western world and is being studied and researched in Western medicine, and plays a very important role in the treatment of anxiety and OCD. It can be packaged in more structured psychotherapies like mindfulness-based stress reduction, MBSR, or mindfulness-based cognitive therapy, MBCT. But for the purposes of tonight, I'll speak about it more broadly. The 4 main principles of mindfulness involve cultivating awareness, so getting to know your inside world, paying attention on purpose to what's showing up inside, orienting to the present moment. Often our mind might be ruminating about the past or worrying about the future. Mindfulness is about coming back to the here and now, and doing this in a non-judgmental way with a spirit of curiosity and kindness. A really helpful analogy that I like is if you think about an itch, what do most people do when they have an itch? They scratch it. In fact, as I'm talking about this, I imagine people are finding an itch on their body and reflexively already scratching it. But imagine for a moment you have this itch and you practice just sitting with it, just observing the itch. Perhaps you notice the physical qualities of the itch. If it's moving around or staying still, you notice your urge to get rid of it and to alleviate the itch. Maybe you scratch it with your mind before scratching it with your fingers. This is what mindfulness teaches us, to be open to an inner experience, sit with it, be with it, without reacting to it automatically and unconsciously. It opens up some choice and flexibility about how we choose to respond. And this is really relevant when we're talking about anxiety and OCD, because in these anxious moments, everything in our mind and body is screaming, this is urgent. I desperately need to feel better and get rid of this. And mindfulness can help slow things down, be with it, and open up some choice in terms of how we respond. Some common myths about mindfulness is that it's not relaxation, it's not the power of positive thinking, it's not mind control, and it's not about stopping thoughts either. There's many different ways that we can practice mindfulness. Meditation is one way. It's not the only way. Stretching and movement-based exercises are another great way to practice mindfulness. This can look like yoga, but it can also look like mindful walking, which is a very accessible way to practice mindfulness. But even doing light stretches in your own environment, or even if you're sitting at your desk. And this last one is my personal favorite. I'm biased because I'm an occupational therapist. Anything that you do daily can be done mindfully. If you think about the mundane tasks of daily living, dishes, brushing your teeth, driving, Often our body is going through the motions of these activities, but our mind is completely elsewhere. This can be a really great opportunity to practice coming back to the task at hand and immersing ourselves into the activity that we're doing. Peggy talked a lot, Dr. Richter spoke a lot about cognitive behavioral therapy, so I won't repeat anything that she said, but this is, I'll just emphasize again that this is one of the most effective treatments. It is has a ton of research to back up its effectiveness. It is the gold standard treatment for anxiety disorders and OCD. Here are some general principles of cognitive behavioral therapy that are transdiagnostic. They apply across the anxiety disorders, and as well as if you're working on OCD. A couple of things I'll highlight. It requires active collaboration between the client and the therapist. For best outcomes, this isn't a passive therapy. The clients that show up prepared, they own the work, they have ideas, they collaborate with their therapists, they tend to get really good outcomes and do really well, because ultimately the goal is to help the client become their own coach and therapist. Treatment, 1 round of CBT for mild to moderate symptom severity is usually 12 to 15 sessions. Sometimes it can be longer than that, and people often benefit from maintenance or booster sessions. Homework is crucial. Practicing the skills that are taught outside of the sessions is a huge predictor for treatment success and treatment outcomes. And it's a skills-based therapy, which means, like learning any new skill, what you put into it is really what you get out of it. The more you practice, the more you will progress. Exposure therapy is a form of the behavioral intervention, the B of CBT. And I'll just speak to this little image I have with this brain lifting weights. You can kind of think of exposure therapy like a mental workout. If you think about physically working out, if you want to get fit, you want to get stronger, again, it requires hard work, discipline, consistent practice. And the same thing goes for exposure therapy. We're promoting these new pathways and new learning in the brain, and we really want to flex those mind muscles frequently and regularly throughout the week. The way that exposure, or in the case of OCD, exposure and response prevention works, there's a few different ways. One is through a process of habituation, which basically means the more you do something, the easier it gets, and the anxiety associated to that trigger or situation reduces over time. For many people, that doesn't happen, but they learn to tolerate their anxiety. They learn that anxiety is actually safe and more manageable than maybe they initially thought. They also learn a lot of new things about their ability to cope and their ability to do hard things, things that they were never doing before. And this last point on the slide, I think, is extremely important to emphasize, because exposure therapy and exposure and response prevention sometimes gets a bad reputation because it involves confronting fears, and people are concerned that it's really scary and hard to do. But really the goal is to help a person reclaim their life and get back to doing the things that they love. Sometimes when we live with anxiety, our world can become very small and narrow, and we stop living and stop engaging and participating in meaningful activities. And the goal of this therapy is really to help people get back to doing those things. Dr. Richter spoke about this, so I'm going to skip over that. A quick note on inference-based cognitive therapy. I won't go into too much detail about this. I just wanted to mention that this is another specialized treatment for OCD. It's a cognitive intervention, so it falls under the C of CBT. It's different than traditional CBT for OCD, and it does not involve exposure and response prevention. So if traditional CBT did not work for you, or for whatever reason you were not able to participate in ERP or traditional CBT, you might want to look into inference-based cognitive therapy. It looks at the different types of reasoning processes that lead the person to their obsessional doubts. And this is called inferential confusion, which is where the therapy gets its name from. My next slides draw on a number of different therapies. I've kind of picked and chosen a few different techniques that are effective in the treatment of OCD and anxiety. The first is cognitive diffusion, which is a set of techniques from acceptance and commitment therapy. If you think about an anxious thought or an obsession, often when it pops into the mind, the person can become very stuck to their thought. It almost feels like I am my thought, and it defines me. It feels very real and believable, and we're very hooked into these sticky thoughts in the mind. Diffusion is a way to help kind of get some space or create distance between you and the thought. So this set of techniques is all about giving us some distance from our anxious thoughts. Examples of cognitive diffusion. So there's literally hundreds of cognitive diffusion techniques, but a couple I thought I'd highlight. One is singing your anxious thoughts or obsessions to various tunes until they lose their power. I won't demonstrate this tonight, but it can be very effective. Stating your thoughts or obsessions in funny voices. I've included an image of Marge Simpson on this slide. I once had a client that had very distressing harm obsessions, and initially they were not able to verbalize these thoughts out loud. They came with tremendous amounts of stress and shame. And through working together, we practice diffusion in the form of them stating their obsessions in Marge Simpson's voice. And I'll never forget that moment where the client is, laughing, and we're both kind of laughing together because it really took the power away from these ideas. It didn't change that they didn't, these thoughts were unwanted and they didn't like them in any way, but it made the thought feel a bit lighter and easier to coexist with. This last one is also a really good one. You start by stating the thought itself. So for example, you might say out loud, something bad is going to happen. And then in the next round, you would say, I'm having the thought, something bad is going to happen. And then in the third round, you would say, I'm noticing, I'm having the thought, something bad is going to happen. Again, with each iteration, putting a little bit more space and distance between you and that idea, which allows you to relate to it a little bit differently, and the believability often goes down. Dropping an anchor is a great technique. It also comes from acceptance and commitment therapy. And the idea here, like the name suggests, is sometimes when we're experiencing an emotional storm, we want to stay put. We want to stay grounded and rooted amidst this storm and not get knocked out by any emotional waves that might be brewing inside us. And you can do this technique by remembering the acronym ACE. The A stands for acknowledge, which involves acknowledging what's coming up inside. The C is come back to the body, to ground and stay present. You might do things like push your feet into the ground, push your fingertips together, shoulders back, stretch your neck out. And then the E is engage in the activity you're doing mindfully. And there's scripts for this technique online, and They vary from 30 seconds to several minutes, and you can kind of build up your tolerance if you like this technique and go through some of the longer prompts if that's helpful. Distress tolerance skills. This comes from dialectical behavioral therapy, or DBT. One set of techniques that can be really helpful with anxiety are called the TIP skills. Distress tolerance is helpful when the intensity of the emotion or the intensity of the anxiety is really high. So, 9 out of 10, 10 out of 10. And it's difficult to engage in some of the other techniques I talked about, breath work or mindfulness or cognitive or behavioral strategies. The first thing we want to do is ground the central nervous system and help break down some of the adrenaline and cortisol that's pumping through the system. Things that you can do that fall under distress tolerance skills. One is using temperature, so using very cold water. The traditional way of doing this is to actually submerge the head in a bucket of ice water for about 30 seconds. And this activates the dive reflex, and it will slow down your heart rate and your breathing rate. But that's not always accessible. So sometimes people will splash cold water on their face or use an ice pack or even take a really cold shower. And that can kind of help also activate the parasympathetic nervous system. Intense exercise. So I really like the phrase emotions need motion. In this, we're talking about expending energy by doing intense bouts of exercise. So it's not about going to the gym. It's more running on the spot, doing jumping jacks, maybe jumping around your living room, dancing to some, heavy metal or fast-paced music. Another one that I don't have on here is sometimes it can be really helpful to use like a very strong mint or have a really sour candy like a warhead, because it creates a competing response to the anxiety and something else to bring your attention to. And that can also help when the distress is really high to have this different sensory experience. One-liners. So these are things, kind of comebacks or things that you can say to anxiety or remind yourself of in the moment. I'll highlight a few. The first one, thanks brain, but no thanks. We might not be able to control the brain sending us an obsession or an anxious thought, but I do get to decide if I grab onto it or not. That kind of goes into the second one. I don't have to answer the questions my brain asks. Another great one is what we resist persists. Again, speaking to this paradoxical nature of working with anxiety. The tendency is often to struggle with it or push it away or try to get rid of it, and that actually reinforces it. If we can learn to be with anxiety and feel anxiety, the better we will actually feel. It's never too late to turn the day around. Maybe a little bit cheesy, but I think that's also a helpful reminder. If anxiety is getting the best of you, every moment is really a new moment and opportunity to show up differently and try something new. And the last two, again, just helpful psychoeducation reminders about anxiety. Self-compassion. Self-compassion is something that I think we're starting to talk about it more and more, and it plays such a valuable role in treatment for anxiety and OCD. This is really about offering oneself the same kindness and care we'd give to a good friend, being gentle and understanding with ourselves, honoring and accepting our humanness, and that suffering is part of the human experience, and that none of us are perfect. Sometimes when we have anxiety, we unintentionally add layers of distress onto our experience, because then we blame ourselves for this anxiety, or we have shame about this anxiety, or we're really critical with ourselves, or we get mad at ourselves. And that can make things a lot heavier and harder, and also make treatment a lot more challenging. So one technique that comes from self-compassion is called the best friend technique, or the friend technique. You can think about a recent time you felt anxious. How did you respond to yourself? What did you say? What was your tone? And then ask yourself, would I use the same tone and say the same things to a friend? How might that differ? And then a quick note on coming back to basics. I think sometimes we forget about this. The foundations of well-being and looking after our basic needs are necessary for positive coping. And sometimes we can get in this feedback loop where anxiety and OCD make us neglect our basic needs. But the more we neglect our basic needs, the more it can also exacerbate the symptoms of these conditions. So while you're waiting for treatment or alongside treatment, it can be really valuable to work on these different things that I've listed here. And just a list of resources. I'll highlight a few. If you like the 3-minute breathing space, you can find this on YouTube by John Kabat-Zinn. Act Mindfully for diffusion or dropping an anchor is a great website by Russ Harris. He has a lot of free resources on there. Dr. Richter mentioned Anxiety Canada. Kristen Neff's website is wonderful for self-compassion resources. For inference-based cognitive therapy, if you put that in your Google search bar, it will bring you to the website, which has a list of treatment providers, as well as a lot of self-help resources. If you're a podcast person, these are 2 wonderful evidence-based podcasts, OCD Stories with Stuart Ralph, and then Your Anxiety Toolkit with Kimberly Quinlan. Mostly focuses on OCD as well, but also other anxiety conditions. Apps, these are some free and evidence-based mindfulness apps. There's tons of mindfulness apps that exist. Some of them do have, hidden fees associated with them, and some of them are not all evidence-based. The ones listed here are, so those might be useful to note. And then lastly, some books for some self-help workbooks that are useful for OCD and anxiety. And that's it. Thank you.
Thank you very much, Elisa. That was really excellent. Particularly enjoyed the experiential exercise. So it was very helpful and much needed on a personal level. I can say I appreciate it. I think others probably did as well. So thank you for that. And so we'll now switch over to the last formal talk of the evening before we open it up to the Q&A afterwards. And I've got the pleasure to introduce our final speaker, Cassie Josephson. Cassie is a registered nurse based in Regina, Saskatchewan, who previously was a client at Sunnybrook's Frederick W. Thompson Anxiety Disorder Center. She received care as part of the center's residential treatment program, which is quite unique, first of its kind in Canada. And Cassie has kindly agreed to share her experience and her story of living with anxiety and OCD in the interest of helping others going through similar experiences. Cassie, we're very grateful that you're joining us and sharing your experience tonight. And with that, I hand it over to you and looking forward to hearing your perspective.
Awesome. Hi. Okay, I will just go right to my slides and start from there. Okay. Hello, my name is Cassie, and I'm here to share my personal story living with anxiety, depression, and OCD. A little bit about me. I'm a registered nurse. I work in pediatrics, but I started my nursing career in long-term care. I have 2 nieces who are my pride and joy. I love animals. I have 4 cats. I've fostered over 150 kittens and cats. I train cats, dogs, and horses, and I have anxiety, depression, and OCD. Growing up with anxiety and OCD, how did they first present? So in hindsight, looking back at my childhood, I think that I've had anxiety and OCD to some degree my whole life. From toddlerhood, I needed to have things a particular way. I needed to have 2 or 3 soothers at a time. My clothes always had to feel just right, sometimes needing to be worn inside out or rearranged until they felt perfect. My school bus driver would often wait for me while I put my left sock on my left foot and my right sock on my right foot. Then my shoes would mess up that right feeling and I'd have to tear it all off in a panic and I'd start all over. I was always told that I was a controlling kid. I did everything I could to control my surroundings. I needed to be in charge and I needed things to be my way. I recall defining moments in my childhood where certain rituals began. For example, my dad coming home from work with a cut on his head. After that, I feared that he'd hurt himself badly at work and die. So every day before work, I'd run to the back door, open it up, and call out to him, "Don't hurt yourself and be careful where you hurt yourself, and don't hurt your head and don't get any nails in your feet." I remember checking the mailbox once and there was a spider in the bottom. After that, every time I passed my mailbox, I'd open it up, get a good look at the bottom, and make sure that there was nothing in it. Once I was playing with the light switch, trying to figure out what would happen if I held the light switch perfectly in the middle. Would the light be half on and half off? Instead, the switch sparked. From then on, I was terrified that if the switch wasn't all the way on or off and happened to get stuck in the middle, that I would cause a house fire, everyone would die, and it would all be my fault. After that, every time I passed a light switch, I'd have to touch it to make sure that it was safe. As I got older, nothing felt truly in my control. My mind felt chaotic or tumultuous. I worried about everything and overthought everything. My brain would automatically go to the worst case scenario. I catastrophized. I'd stress about what everyone else was thinking. I'd stress all the time about not being good enough. I feared winter driving. I actually used to have panic attacks while my classmates drove me to school. I'd replay situations over and over again in my head, worried that I could have done better, been better, said better, or done differently. So I'd start to do whatever I could to gain control, to get that just right feeling to calm the panic that I felt inside. I had just started my 4th year of nursing school, and I could see the finish line. I'd even already taken my graduation photos. My depression, anxiety, and OCD were getting worse, so I decided to take the first steps towards getting help. I started by trying free counseling at my university, but I didn't really feel like that was a good match. I wanted to find a psychologist, so I looked up some local clinics, picked one out, and scheduled an appointment. Of course, there was a waiting list, so I didn't get in right away. As time passed, I was mentally in a very dark place, so I opened up to one of my clinical instructors about my mental health and my struggles. She brought me to talk with her and another staff member, and together we made a safety plan. It was the day after my 21st birthday, and I was not confident that I would be able to keep that safety contract. So I went to the hospital for help. I had to take a medical leave from school for a semester. It was during my first hospital stay on one of my passes that I was actually able to go and meet with my psychologist. I really lucked out with her, and I've been working with her ever since. I could go on forever about the positive impact that she's had on my life. It's so important to find a psychologist or a therapist that you work well with and that you mesh with. I started obsessing over the number on the scale, 96 pounds, because that's divisible by 3. The number 3 gave me a sense of comfort. I told myself that if I could just reach that number, that sickly number, and achieve that goal, that I would feel satisfied and settled. There'd be order in this world, and maybe then I wouldn't hate myself so much. 8 months later than originally planned, but still in the same calendar year, I graduated from nursing school and passed my licensing exam. I refused to give up, and I achieved one of my life goals. I got a job working in long-term care and worked for about 1.5 years. I continued to struggle immensely with my mental health, and I had to take a break from work, eventually going on to long-term disability. Over time, my magic number became 3, and any multiple of 3. It slowly crept its way into everything. The more that I gave room to those obsessions, the bigger they grew and the more out of control they got. The multiples of 3 started harmlessly. Passing a light switch, touching it to make sure that it was on or off and counting to 3 and then moving on. Locking my car 3 times, flicking the water off my hands 3 times, taking 3 pumps of soap, scratching my head 3 times, petting my cat 3 times, touching an object the right way and counting to 3. Over time, just 3 wasn't enough to feel just right. I had to do those tasks and count to 3 times. Then it turned to counting to 3 times 3 times. Then I started doing these tasks while driving, like my shoulder checks, the amount of times that I let my wipers swipe, how long I came to a complete stop for. That got so out of control that I had to stop driving after running a red light and nearly getting T-boned because I was too focused on my wipers. If I didn't do exactly as my OCD thought I should, I felt like a complete failure, and I felt like I lost that control. I'd get an intrusive thought, it would get trapped in my head, and I'd endlessly obsess over it until I completed the thought or the action of the thought. My OCD would then quiet, or so it told me, but there would always be that darn repeat button. Walking became so difficult that I stopped being able to take my old dog for walks. I couldn't step on cracks, and I could only step over them with my right foot. Walking on tiles, my OCD told me which tiles I was allowed to step in. Every step I took was controlled and calculated. I started looking pretty silly walking around with my stride being all over the place trying to abide by my OCD. Probably one of the most malevolent obsessions and compulsions that my OCD had me doing was inflicting pain on myself. Not in the harm OCD category, but still in that just right OCD and that need for completion. I already had major depressive disorder. I was so low that I did have suicidal ideation. My OCD was really sneaky though, and it clung on to those thoughts stemming from my depression. The thoughts were already there, but now they were on repeat, and I had an exceptionally hard time putting them down. It had me obsessing over overdosing. I didn't truly want to die. I didn't want to be successful. That's what made it all the more terrifying. I just needed the OCD to stop yelling so loudly. I did everything that I could to quiet it without giving in to that compulsion. Was I always successful? Sadly, the answer is no. The first time that I overdosed was December 2015. And what would you know? OCD lied to me. Yes, my OCD did quiet down, but it hardly lasted. A short 2 months later, I acted on that compulsion again. In 3 years, I gave in and listened 4 times. I had yet to learn the skills to give zero power to my OCD, so instead I bargained with it relentlessly. I tried to appease it by doing different forms of less harmful, aka non-fatal self-harm. But those just became new obsessions and compulsions too, having to do them in threes or until it felt just right. In times of immediate crisis, I went to hospital for inpatient treatment, but I always had a different psychiatrist whenever I was admitted. Many doctors didn't believe that I had OCD. Well, others did, but they didn't believe that it was my main issue. Instead, I was misdiagnosed with borderline personality disorder because of my self-harm. Sadly, while in hospital, this had an extremely negative effect on the way that I was treated, causing me trauma, and overall was counterproductive towards my recovery. It put me on a treatment plan that did not fit my needs. Having nearly constant intrusive thoughts running on repeat made me pretty anxious and depressed, so I was given one med after another. Nothing seemed to work very effectively for me, or I'd have terrible side effects. We even actually tried transcranial magnetic stimulation, TMS, and electroconvulsive therapy, or ECT, more commonly known as shock therapy, which are both methods of treating treatment-resistant depression. In 5 years and 4 months, I spent a total of 7 months, or 210 days in inpatient mental health. I was put on quite the cocktail of medications, and I wasn't improving, even despite the hours of therapy I was putting in weekly for years. My psychologist went above and beyond, and together we worked tirelessly doing CBT, ACT, DBT, and we even tried doing some ERPs. But what I really needed was intensive and specialized OCD treatment that was not available here in Saskatchewan. There was actually only one treatment facility in Canada, and that's when I found the Sunnybrook Thompson Centre. The Thompson Center's treatment and treatment team were life-changing. It was pivotal in getting my life back. Finding a whole team of professionals who specialized in OCD, who truly understand your struggles, who don't judge you, and who actually know how exactly to help you. The staff are all phenomenal. The main treatment was exposure and response prevention, or ERP. And it's no walk in the park. Although ironically, one of my exposures was walking in the park. I created an exposure hierarchy, which is a list of situations that trigger your OCD, and you rate them from least distressing to most distressing. You start with the least distressing and you work your way up that ladder. But the staff are there with you every step of the way. Say you have a panic attack and you're curled up on the floor, which happened to me a lot. They'll sit right beside you on the floor and help you through it. They don't just throw you into the deep end and hope that you can swim. They teach you skills and techniques, and you leave the program with your toolbox fully stocked. They help you to see your own strengths, and they see you for you, not your illness. Tools and techniques that I learned and found helpful for my OCD were ERPs, doing distress hierarchies. This is a picture of my old dog and I on our first walk after I came home from the Thompson Centre, something that working through my distress hierarchies helped me to start doing again. CBT, doing thought records. DBT, learning distress tolerance and understanding your emotions. ACT, keeping in line with your values, dropping the anchor, noticing when you're being hooked by unhelpful thoughts, and that choice point, choosing either away or towards moves. So it turned out that for quite some time, I actually had serotonin syndrome, which is a very rare complication on being of high doses of so many medications. It was amplifying my anxiety and my depression. December 2021, my body quit working and I fell unconscious and spent 9 days on a ventilator. It was a lengthy recovery mentally and physically, but every day that passed after making it off that vent, I felt clearer. I was actually able to finally start effectively using all my CBT, ACT, and ERP skills that I learned, and I was finally on a smoother path. I continue to regularly see my psychologist. I do ERPs myself every single day. The more that I incorporate them into my everyday life, the easier they are to do. When tasks start to feel too comfortable and those patterns start to bring too much satisfaction and feeling just right, I switch it up and I do a pattern that feels completely wrong. I know the mountains that I had to climb and the trenches that I had to dig my way out of to get where I am today. And I still feel a sense of pride and accomplishment with every exposure that I do. I can quickly recognize when I'm being hooked by unhelpful thought patterns. I'm able to anticipate situations and triggers that are going to aggravate and threaten my OCD so that I can actually brace for the wave. I notice and make space for my thoughts and feelings and remind myself that they don't hold any power. Instead of acting on them, I take steps that align with my values and my goals. I accept that in life, there are so many things that ultimately we don't have control over. I try to always do things that I love and enjoy. I keep taking steps forward, and I try my best to go with the flow and roll with the punches that life gives. After 4 years on long-term disability, I started back at work. I started a brand new job in pediatrics, which was another one of my life goals. I've been working there for a little bit over a year now. I've started actively searching for a house to purchase with the goal of buying and moving into before this fall. I'm taking steps in my life and meeting goals that I was starting to believe would never be possible for me. I went to LA by myself to see Taylor Swift. I've taken trips to South America and Asia to visit my nieces. I even actually took a detour away from the airport on my own on my way home to venture into Japan all by myself. Yes, I still have ups and downs, and I have a lot of struggles, but they do not control me, and they sure do not define me. Thank you for listening to my story. Believe that you can, and you're halfway there.
Cassie, thank you so much for sharing that and your inspirational story and journey. Congratulations on all that you've achieved. Congratulations also on getting Taylor Swift tickets. I know that's also a tough thing to do, but it takes tremendous courage to share your personal story like this, but it is so incredibly helpful to hear. It really puts a face and a sense of experience on why we're trying to help and do the work that we do. And for others to hear your journey, I think is absolutely kind of profoundly important. So thank you so much for that. With that, it does actually conclude the formal presentations for the evening. We'll start the Q&A portion in a moment. Just a reminder, we have gotten a number of questions that we'll start with, but you can still submit questions, and you can do that on the Speaker Series website. And so I think what I'll do in starting the questions, I'm going to start slightly out of order. And Cassie, if it's okay, I'll actually turn the first one over to you, because this was one that somebody asked. What are some of the tips that you can share that help to reduce anxiety at the moment while you're experiencing it?
Okay, so in the moment of big anxiety and panic, my go-to is using grounding techniques. So one that I really love doing is we have 5 different senses. So naming 3 to 5 different things in each sense. So 5 things that you can see in this moment by looking around the room and saying them out loud what you can see. 5 things that you can hear. It might even just be like the hum of the air conditioning or heating or anything, or your own voice. 5, or sometimes it's kind of hard to find 5 things that you can taste or smell, but you can even smell your shirt or smell your hands, just finding things to smell in that moment. And then, yeah, seeing, hearing, tasting, I'm blanking. Seeing, hearing, tasting, feeling, and there's one more, and smelling. Yeah. That's my go-to to kind of calm me in the moment. And then just remembering that in the present moment, your anxiety is telling that you're in danger, but looking around and reminding myself in this moment, I may feel like things are dangerous, but they're not. I mean, unless you're truly in a dangerous situation, but as I'm sitting here and I'm anxious about sharing my story, something like that, I'm sitting here in a room and I'm not in any danger. So I try to remind myself of that too.
Great. Thank you very much, Cassie. Eliza, Peggy, anything to add before we move to the next question? Okay, if we can loop back to it if anything does additionally come up. So another question was, are there any new approaches to erasing or dulling conditioned responses that trigger extreme anxiety? Examples being things like EMDR, so that's the eye movement desensitization therapy, medications or drugs, and things that can help deal with severe phobic reactions that compromise quality of life. Maybe for this one, Peggy, if you could kick it off, and then Eliza and of course, Cassie, if you have anything to add afterwards.
Sure. So wouldn't it be wonderful if I could start by saying we have a major breakthrough that will treat anxiety wonderfully right off the bat? Unfortunately, that's not where we're at. But there are some interesting developments. I know the questioner, the person who submitted the question, asked about EMDR. I would not call EMDR in any way a breakthrough for anxiety, although it is being used a little bit for OCD as an alternative. And there is some evidence, certainly, that it works, but no better than other things in our toolkit. I think there are some things that show promise, or at least are things we're interested in that we believe to be promising. So some of those include some newer agents, those that work on different brain transmitter systems called glutamate and GABA. So one of these is something called D-cycloserine, which actually helps with fear extinction or unlearning the fear response, and has been paired with CBT in the hopes that it would speed up the way CBT works. Unfortunately, so far, the evidence is pretty mixed. It doesn't look like an amazing breakthrough, but I think there's still room to look at how best to use it. So I think that may still be an opportunity. Ketamine is something many people are familiar with. It's kind of a psychedelic drug, but also has been used in anesthesia for many, many decades. And at this point is considered a major breakthrough drug for severe treatment-resistant depression and suicidal thinking. Unfortunately, in anxiety and OCD, it's not showing that same breakthrough potential. I think there's a lot of interest in the hallucinogens, though, more generally, or the psychedelic drugs. And I think a few of these are looking particularly interesting. I want to caution people that by saying this is not licensed to go out and buy them or try them on your own. But for example, there are quite a few studies now involving LSD or psilocybin for treatment of end-of-life related anxiety, severe depression, and post-traumatic stress disorder in particular, typically in tandem with therapy with a skilled therapist. So they're done in very carefully controlled circumstances with a therapist on hand in the context of a trusted relationship. And these are showing real promise as breakthroughs, but at this point, we're not yet there, I'd say.
Thanks, Peggy. Thank you very much for that information. The next question, actually, Elisa, you touched on this a bit in your presentation, but I'm just wondering if there's anything you want to expand on this. And this was a question about any advice on the best ways of dealing with health and health-related anxiety.
Cognitive behavioral therapy would be first-line treatment for health anxiety. The one nuance with working with health anxiety is it might be beneficial to get an interdisciplinary approach. So to involve your family doctor in the care, especially if you're, seeking frequent medical appointments, and they're doing investigations and tests, to find that balance between doing appropriate medical assessment and balancing that with not feeding into the anxiety in any way. So sometimes the therapist, the client, and the family doctor working together to be on the same page and have a plan can be helpful. And that also might involve postponing or delaying, having some guidelines or a framework that the client can refer to help them with that decision making when the anxiety is telling them, this is urgent, this is imminent, go to the emergency now, or go to make the appointment now, to help delineate what might be anxiety from a medical concern that requires immediate attention.
Great, thank you. I think the next one, let's actually toss it open to the panel and whoever would like to sort of start in on this one. And the question is about whether avoidance of conflictual situations can sometimes be more beneficial than harmful.
So maybe I'll jump in first and say, from a treatment perspective, avoidance is kind of the enemy of recovery, in the sense that the more we tend to avoid these triggers, the more our anxiety grows. And that's really the principle behind exposure therapy that we've talked about for the anxiety disorders, which is one of the key ingredients in cognitive behavioral therapy. So as a general rule, we want to encourage people to start going back into situations that are triggering. And for many people, even without CBT, simply knowing that that's helpful can, in fact, lead to changes. I guess the one caveat I'd make is that there needs to be a bit of a judicial balance around this. And if somebody is really disabled by severe anxiety and maybe not yet ready for certain situations, then avoidance may be helpful in smoothing the way until they're at a stage where they're ready to take them on. So that would be some of my first thoughts about that.
Thanks, Peggy. Cassie, Aliza, anything to add on this one?
Yeah, I would say avoiding the situation definitely makes it worse, at least for me. And the more that I avoid it, the more it builds and builds and builds, and the scarier it gets and the more daunting it seems. So I think that's kind of like with exposure and response prevention. The more that I do ERPs every single day, they're not big, huge things. They're small. In the beginning, they definitely were. So I think it's in the long term, it is much better to not avoid the situation.
Okay, great, thank you. And just to let people know, we're monitoring the questions that are coming in. So we do have a number of questions now, and just given the time, we will hope to try to get through all of them. But it is possible, I don't want anyone to feel upset, but it is quite possible that any additional questions we may not have time to get to. We'll do the best we can. But for the next one, I actually think turn to this. I remember, Peggy, at one point you were talking about the quite high number of people who end up not actually getting help for the care that they need when they have anxiety disorders, when they have OCD. And so this question, I think, also links to that. And the question is, how important is it to get a diagnosis from a psychiatrist or a doctor before getting treatment?
It's a really good question, actually, because I think traditionally most people would have answered that's critical. That's the way we have to go. And it often is it's often very helpful, and sometimes it's actually necessary. But having said that, I think increasingly we also recognize that there are a whole lot of licensed healthcare professionals with good knowledge and training around management of anxiety conditions. And so I think if seeing somebody who's well trained and you have the opportunity then to start treatment right away, particularly if the case seems relatively straightforward to the professional, then that can be just fine and a good way to get started without waiting a long time, particularly in people from smaller communities where, getting in to see a doctor, and particularly a psychiatrist, may be a real challenge. I think if the conditions are more severe if dysfunction is higher, if people are having significant suicidal thinking or self-harm, those would be obvious warning signs that clearly something more significant is needed. And certainly with more concerning presentations with more severe illness, seeing a psychiatrist as soon as possible would be really part of the treatment plan in terms of being able to at least have a clear picture of what is going on and what treatments will be most effective.
Right. Thanks, Peggy. Important question, and thanks for the nuanced answer. I think for the next one, probably if Lisa and Cassie are able to each weigh in. And this asks, does therapy like CBT need to be ongoing to be effective, or do patients eventually not need it anymore?
I can start. In terms of participating in a structured CBT program, that usually has an end date. You would participate in a hospital or in a treatment center. But the practice of the skills is ongoing in order to continue to reap the benefits of it. We often talk about living the CBT lifestyle or living the ERP lifestyle. And essentially, we encourage folks to practice applying these skills in their day-to-day life, and to make it as routine as brushing their teeth for, ongoing oral health. You might have to, like Cassie was talking about, do her daily dose of ERP or exposure therapy to continue to reap the benefit from these interventions.
Yeah, I think I could really echo that too. In the beginning, you might need much more intensive for a while. For me, I learn, it's almost like I hear my psychiatrist or my psychologist when I'm doing situations and talking through. Now I'm almost my own voice talking myself through these thought records and situations. But for me, it's also great to just like once or twice a month now, I'll see my psychologist just for those check-ins. If that's feasible, I think that's great to just kind of have someone to hold you accountable to it. But yeah, definitely doesn't need to be a constant thing. Going to a physical person, but doing it yourself, yes.
And actually, just on that, I think it's interesting because Peggy, you were talking about how medications, one of the downsides is that when you stop medication, you can lose the impact that it may have been having. And with CBT, you may continue the CBT therapy on your own, or at least the techniques on your own that you've learned. So I think that's part of what you were alluding to, Cassie. I think that's very important. Okay, so this question actually has to do with relational issues and parenting. So can negative parenting, for example, the fear of abuse, cause or complicate OCD? And you may each have a perspective on that. I see you're nodding your head, Peggy. Do you want to kick it off?
Sorry, that's such an interesting question. So I guess I'll start with my actual stock answer, which is around trauma, because it comes up an awful lot. And certainly childhood abuse would be one type of very serious trauma people may experience in their lifetime. And so the question often comes up, does trauma cause OCD or other problems? And the answer from my perspective, and based on what we know at this point in time, is that trauma raises our vulnerability to everything. Another way of looking at it is that it reduces our resilience to everything. So people who've been severely affected by trauma typically are less able to manage these things if they start coming on, and as a result are probably more likely to develop any one of a number of mental health conditions. But generally speaking, it's not specific to one condition or another, aside from risk of depression, which very clearly is tied into trauma. So people with OCD may have higher risks of trauma than the general public, but it wouldn't be higher than people with depression or people with other kinds of mental health conditions, if that makes sense. I hope that answers it, Sonu.
I think it does. And what I'm going to suggest is that we have a number of other questions, and we've got about 5 minutes, 6 minutes left for the Q&A. So maybe I'll go on to the other questions if that's okay. And we've got, I think, reasonably good chance of getting through almost all of them at least. And so this one is a little bit more specific. And again, just as a reminder that it's not something where in the series we're able to give specific advice for any, one person or one person situations, one person situation. So this is a bit more specific, but there can also be a general answer to it. And the question is, what would you recommend for skin picking issues? So I guess also known as dermatillomania, I guess would be the actual term. But what would you recommend for that in general?
So actually these days, skin picking or actually excoriation disorder is another term we're using more recently, although dermatillomania was certainly an older term that was out there and still is used a lot, is a recognized mental health condition, recognized by the Bible of psychiatric illness, as I mentioned before, the DSM-5, which is good because when something is recognized and has a name, we can do better in terms of treating it and better in terms of researching it. So there are treatments for skin picking. It can be responsive to some medications, although not necessarily identically to OCD. There is also very specific types of CBT that is done for both skin picking and the related condition of hair pulling or trichotillomania. And CBT specifically for those conditions can be very helpful. There are great resources on the International Obsessive Compulsive Disorders Foundation website, or iocdf.org. I'll say that again since I don't know I can share it visually, but iocdf.org, which is the leading international organization for people with OCD and the related conditions, and they have great resources there.
Great. Thank you, Peggy. And this one is for Cassie and starts with a comment. I think that many of us want to express, but congrats to Cassie. Just wondering, while she was going through her challenge, did she ever see light at the end of the tunnel?
Thank you. And it was pretty dark for quite a long time. I saw flickers of light when kind of towards the end of my intensive OCD treatment, but the light really kind of blew up once I recovered from my serotonin syndrome, and then everything just kind of started falling into place for me. And when I was really using all my skills and stuff, and yeah, that's when the light really shone bright for me at the end of the tunnel, and I feel like I'm out of that tunnel now. So in the middle of it, no, I just kind of kept having to keep looking after myself, even though I didn't really see much light.
Well, Cassie, thank you for that. And it's great that you're seeing a lot more light now and clearly living a kind of fulfilling life that way. So that's a really great place to be in. Congratulations on that. And so we've got two more questions. I think we will get through them. First one, I'll toss over to you, Peggy, because you did touch on this, and I think this is probably a relatively short answer, but is long-term medication, such as SSRI use, recommended for severe OCD?
Really important question. So I'll start off by saying that for people who are fairly early on in an illness, if they have a good response to a medication, very often we talk about trying them for about a year and then seeing how they do without them. And that would be a great typical starting point. However, if the illness is more severe, more chronic, or has been resistant to a number of trials of medication, that's when we begin thinking about more long-term use. And for many with more severe OCD, such as being asked about in this question, yes, we would talk about long-term use. Whether lifetime or over the years and then trying a gradual taper is debatable. Many people can taper down the dose at some point.
Great. Thanks, Peggy. And then for the last question, actually, Elise, I'll look to you to kick it off. And then if either Cassie or Peggy want to add in, please do so. And then we'll kind of conclude after that. And the question is from a family member. So as a family member, what is the best way to be supportive, but not feed into the anxiety?
It's such a great question, because again, how we work with anxiety and OCD is very paradoxical and backwards. The tendency of the family member is to jump in, help, do whatever they can to make their loved one feel better. And often this unintentionally and inadvertently can feed the anxiety or OCD cycle and make things worse. So involving family members in care is highly recommended. We do a lot of family education so they can understand this cycle and this paradoxical nature. And then really having everybody come together and work together. We will talk about a gradual collaborative plan to reduce some of the forms of accommodation that the family member might be providing in those moments. But that doesn't mean they can't help their loved one in other ways that are not feeding into the anxiety or OCD cycle. So we talk about the things not to do, but the things that they can do instead, and other techniques that they can coach their loved one through as part of their toolbox. In the OCD world, we use the term family accommodation quite a bit, and that might be something useful to look into if it's OCD that you're talking about.
Thanks, Eliza. And anything to supplement or add, Cassie or Peggy, from your end, just before we wrap up?
I'd like to add, just being informed is always helpful. So there are lots of places we've talked about already, and there's also information on our website and some of those others I recommended, because the more informed you are, the more you can better help your loved one. And just being there and making sure they know that you are there for them is hugely important and should never be underestimated. And I think Cassie can probably speak to that too. Knowing you have family who care about you when you're going through this makes a huge difference. So in some ways, I'd say the most important thing is just being there for them.
Thanks, Peggy. And any last word, Cassie, before we wrap up? Or I see you nodding, so you agree with what was said. Anything additional?
Yeah, I agree with what was said. I think just support and being there and knowing that you're not alone in it, I think, is the biggest for me.
Okay. Great. Well, this was remarkable. It was really a great kind of evening session, and we've come to the end of needing to wrap up. I expect we could have gone on longer with more Q&A, but we covered, thank you to all the speakers. We covered remarkable ground, but also in very different ways and very poignant ways. So that was I'm very appreciative of that, and I'm sure that our audience is as well. Just a couple of points before we wrap up. One is a reminder, please take a minute if you can to fill out the electronic evaluation forms. Those help us in planning future talks and topics for you. And if you're not already on this, you can add your name to our mailing list for future talks. I want to once again thank our speakers for an incredibly informative and engaging evening, and also to Donna Duncan from our board for providing the welcoming remarks and also for the tremendous ongoing support. And finally, of course, a big thanks to all of you for joining us for this educational event tonight. Please be sure to check out upcoming topics. Those will be shared on the Speaker Series website. And until then, and in the meantime, have a wonderful evening. Stay mindful and be well.